was done, oh, maybe 5 years ago, or a similar version. And then we kind of decided to
So one of the other reasons we're revisiting is we looked at some of the injuries in the quality review last year, and pressure ulcers related to areas around airway management were significantly higher than the hospital and the national average. So the national average around general pressure ulcers is about 1.8. We are 1.6 right now, and trach area is 7%. So we had a significant amount of injury just in that area.
7% of the trach patients get, even
injury.
after we stopped?
No, this is before we stopped the thing.
Okay.
All right, so that said, we're just going to review.
Wait a minute, getting trach oil?
Say it again?
Is that a fact of life by virtue of having tracheostomy?
No.
It's that 7% that's high.
That's extremely high, I think, yeah. So I have that study, so I can give it to you. So the objectives, of course, are well laid out here. I just want to kind of run through some of these slides because they just speak to what's going on. Pressure ulcers, of course, is an observable pressure-related alteration of intact skin, and the indicators are obviously compared to the adjacent skin on the body and include skin temperature, tissue consistency, and/or sensation. We are guided by two of the pressure ulcer panels. One is the National Pressure Ulcer, and the other is the European Pressure Ulcer Advisory Panel. So any lesion causing unrelieved pressure and resulting in damage is really considered a pressure injury. And it can be anywhere in the body, but the primary cause is capillary occlusion. So when the cell is nourished at a certain capillary level, from 12 to 32 milligrams of mercury, when the pressure is added and tissue supply is cut off, blood supply is cut off, you get ischemia and hypoxemia to the cell itself, and it dies. What we have to look at is really the intensity of pressure, the duration of pressure, and the distribution. And so this plays out a little bit more when you look at a big person lying in a bed. And when we talk to nurses, we'll say, okay, this is a giant person, and the areas of pressure are usually on the back side, their shoulders, their scapula, when they're on their back. And certainly if you turn them, you see different areas there. But remember, a lot of the stuff that we use, the devices, are causing a lot of pressure injuries that we have really ignored for a number of years. So the greater the pressure and less time, the less pressure, more time. Pressure ulcer is said to affect 1.3 to 3 million individuals in the United States. The cost is anywhere from $500 to $400,000 to heal just a basic ulcer. Higher percentage, of course, is in the elderly, and elderly is anybody over 65. Acutely ill, and spinal cord injuries. Evidence-based guidelines are always developed to provide the comprehensive evidence and consensus base on all this stuff. So what does it really mean to us in terms of the federal regulations? CMS, the Center for Medicare and Medicaid, is really the people that we have to answer to. They will actually reduce reimbursement in patients who develop any kind of pressure injury within a hospital facility. And it's difficult to place these patients once that happens because we are mandated to document that an injury has occurred and it's occurred within the hospital setting, within our setting. So what we've asked, and particularly in the nursing department and physician, every physician has to sign off now when the patient comes in. Does this patient have a pressure ulcer on admission? And I would say probably 9 out of 10 people really don't do the full assessment of skin because if they did, they would find probably more issues. But the nurses also said to do that, to go in and look at their skin from head to toe. If we miss it in the first 24 hours, we're stuck with it. And if we're stuck with it, we get dinged and there's no reimbursement around anything to do with that wound. So it's really not a cool thing. We always want to document the presence or the absence of pressure ulcers on admission and at discharge, because at discharge, you send them to another facility at what point they said, we didn't do it, it was mass general. They want to know who started it, and that's how the reimbursement goes. The ability of the caregiver to correctly assess wound status and the etiology, you have to know the basics around it. We want to protect really from litigation, and we want to comply with the federal regulations. And we look at the nursing documentation, we look at respiratory documentation as well. So the respiratory note is where you are, safety report if needed, and consult is needed is what we're looking for. From a nursing perspective, we value safety reports. So I know that sounds like you're tattling on somebody else. It's not tattling. In fact, you really don't have to fill out the whole thing. You just have to say, I just saw this injury. It was red, it was whatever, and I just need somebody to look at it. You file that safety report and somebody will go and assess that patient. On your respiratory notes, I know that you've got kind of an upgrade, and there's a picture for staging injuries. I think there's only 4 staged injuries, but it is expanded. So you do have some of the resources needed. But you are also very capable people, and you could write that safety report and hopefully put in a consult. Where we're going with this is we would love for your input. We value your expertise. You're in the room every 4 hours for airway management half the time. You see all these patients day in and day out. You know if something looks not normal. You may not know what it is. You may not know how to stage it, and nobody's asking you to do that. We just want to know, is it normal? Do you think that looks the way it should look? And if it doesn't, to put in possibly a consult to us or to let somebody else know. You are also welcome to put in a safety report. So what we've done, we're actually working on it still, Carolyn and I and Bob, everybody, trying to consider a pressure ulcer wound consultation which goes automatically to the CNS. And this is the POE screen, how to go about doing it. We still have to get access for every respiratory therapist to go to these screens. And the way it looks is you would go into POE, you would find the patient's name, click on it, you would go to the screen right, and then this screen would come up, and you see where consults is. You'd hit the consult screen, and then these consults would come up, and there are tons of them. But the one we're looking for you to look at is pressure ulcer and wound. You hit it, this screen comes up. Is it a pressure ulcer? Is it a wound? Is it something else? And in this little box you'd say, I don't know what the hell it is, because you just come and look at it. Okay? So it's
Or trach side.
trach side, something around the back of the ear from the nasal prongs. The nose has a deep BiPAP injury. Anything with endotube, anything you see that you see is a little bit odd, let us know. So some of the common misconceptions are that all pressure ulcers develop because of poor nursing care. That's not true. All pressure ulcers are preventable. Not true. And the use of specialty equipment will prevent pressure ulcers independently. Again, not true. So the hospital gives us all sorts of resources. The reason CNSs are all about pressure ulcers right now is they're looking for a group to say, how do we prevent it? How do we educate? And what kind of things do we need to make sure that it doesn't happen again? So bringing in special beds, special equipment, you have the same issues here. So when your respiratory equipment of the nasal prongs was all plastic and it wasn't working well, Joe, I think, Neil, Purse, all of you got together and said, you know what, we need those stretchy things over the years. And that prevented a lot of injury for the nasal prongs. Simple stuff can make a big difference. So the facts really are, pressure ulcers are about tissue tolerance. Some pressure ulcers are preventable. Pressure ulcers may be viewed in the overall context of the patient. Remember, examine the whole patient, not the hole in the patient. So look at the whole picture. Nutrition, pressure. You know, these people are, 40% of the people we deal with are diabetics. How many people are on steroids before they even come in? How many people have cancer as an underlying diagnosis? How many people have had radiation or chemo? All affects their skin, all affects their level of pressure. So we use the Braden scale, and you don't have to know specifics around the Braden scale, but I just want to give you an idea. When you see somebody writes Braden scale, it's really the risk for pressure ulcer. Not a great scale, but it's the only thing we have out there right now. And we literally ask the nurses on every shift to fill this out, to click off the number they think. So if somebody's sensory perception on their feet with a dead heel is limited, we would just add a number 3. And we add them all up, and then these are the top scores. Anybody who's really under a 13 on those scores needs an intervention. So some of the preventable pressure injuries that we talked about were anything related to position. So we say, get them a special bed, get them a special pad, turn them now and then. But if we don't actually turn these patients every few hours, then they are going to develop pressure and sustaining those positions for long periods of time. So lack of reposition injury, particularly in the OR, becomes one area that we follow very closely. Had a patient that went down for an esophageal surgery. The standard esophageal surgeries, somewhere between 6 and 7 hours. This patient developed complications, was on the table for 14 hours. When they got to the PACU, they said, well, there's a little bruise under the heel. Don't know what's going on. By the time they get up to LC19, literally the heel would come apart. Wound up, couldn't walk, had both deep pressure ulcers on the heel, all because the heel wasn't moved. I mean, it sounds silly. They now have dolphin mats that they're putting on any of the OR tables that allow for the pressure to be reconfigured, and they're doing it in the cardiac ICU. There's about 5 mats that are preventing some of these injuries. Vented patients, obviously, many of them are turned to that vented side. I think of all the times we had them, they were always over there, and then you go to turn them, and they just want to go back to that same side. So in addition to injuries around E-tubes and trachs and stuff, you get their shoulders and their sides all breaking down as well. Clinical devices are really kind of the big thing right now. So we have to identify potential devices, and the biggie is, of course, respiratory equipment. We jump right on it. So O2 tubing, the masks that people are using. Do we have, like when you put somebody on CPAP, you'll put on a different kind of mask, but some of those CPAP masks are $500 if you get them outside. They have gel in it, they have, I don't know, magical dust inside that prevents them from having injury. But we may just have air inside, and over time that might break down their skin. The airway tubes themselves, and any of the GI tubes, NG, J tube, G tubes, we have a lot of problems with that. And what I didn't put up here was the braces. Anybody with those neck braces, we have had numerous injuries with people behind the head because we didn't take off the front of that. Everybody's afraid. It's not just you. Nursing, respiratory, everybody's afraid to touch them because we think we're going to hurt this patient more when in fact we have to assess them every shift. And that's really important when they're trached underneath those neck braces. So who's at risk in the acute care area? Obviously they can develop within the first 2 weeks. You can have that develop over a period of 12 hours. LIDA has done some research. 15% of the elderly develop a wound within 1 week of admission. And any kind of exposure to new clinical devices, surgical or interventional procedures, obviously makes them more exposed. Long-term care develop within the first 4 weeks, and with the change in condition. The elderly is considered over 65, but we're seeing it in much younger people because we get them sick. They're much sicker, the people that are coming into Boston for care. Neonates and children, of course, less than 3, they have similar issues, mostly at the back of the head that they deal with, but they're also exposed to pressure from tapes and other things that we hold masks and stuff in with. And then, of course, spinal cord injuries and immobile patients. Oncology population is huge, so you're seeing more and more head and neck people coming in, lung cancer patients coming in, and you have to be acutely aware of some of the changes in their treatments. We now give adjuvant radiation and chemotherapy to every esophageal cancer patient before they come in for surgery. And we found out that that was the way to go just in the last 3 years. That said, when you radiate somebody's neck or you radiate their chest, these people are going to have a higher incidence of skin tissue breakdown in that area. Couple that with a little chemotherapy on top, and you really have to think the DNA in their skin has really changed. Anybody with neutropenia is a high potential risk. In the operating room, there's much more increased awareness now. They're putting padding, all these areas, and making sure they document when they turn them and where they turn them. The intrinsic factors, of course, are the comorbidities of their medications and their disease and their diabetes and their ALS and stuff like that. The extrinsic are things that we can actually work on. So tables, time on the tables, and the devices themselves. Those of you that work in critical care, you're going to see a higher level probably of acute injury. And of course the bariatric patients are also at risk, and you'd be surprised. Just some skin, extra tissue, the amount of pressure that puts on other areas of the body, somebody's penis, for instance, or areas around the neck, breaks down quickly. So the guidelines really for us are to address the possible causation, remove the potential for further injury, define the plan of care to assess injury using the evidence-based practice guidelines and maximize their health. We got to reposition them all the time. If someone's sitting in a chair, we ask them to just turn just a little bit every 15 minutes. If they're in bed, it's still every 1 to 2 hours. We're using pressure reduction devices on most floors. The ICUs are all equipped with the sport mattresses, which are really cool. They also have the Dolphin mattresses. On the general care units, we have beds that we are ordering outside. We have to reassess all the devices that may or may not be causing this. And in doing that, we have changed a lot of practice, including respiratory practice, as to what you order and what you buy. But we're doing it in other areas of interventional radiology and in the general hospital population. Wound prep to facilitate wound healing. We're maximizing the potential for decreasing breakdown by putting those 3M barriers on people so it protects them against. We're also maximizing nutrition. Instead of giving them water with their pills, we're giving them higher protein drinks and some of the ICU levels of care. And it should be on general care. Infection control is a little bit more involved. We have systemic and local interventions. Precautions, we're using silver on dressings, we're using different products that have certainly helped, and surgical interventions. Less time on the OR table, more interventional procedures. And then, of course, dressings. I'm co-chair of the Wound Care Task Force that has all the CNSs. We have reviewed all the dressing supplies in the hospital to see what are they good for, what are they not good for. And I'll tell you, we're trying to contain costs and pick the right and the best device possible. So we are looking at that. The best benefit of, obviously, to pressure staging is early detection. Prevention, therapeutic interventions can always be implemented, but clearly just to see it. Staging should never be the sole parameter. You should always look at the whole picture. Just an FYI, when someone comes in and you see it written, oh, they have a stage 3, but it looks better now, so it's a stage 2. There's no such thing as reverse staging. You would say it's an improved stage 3, or it's a resolving stage 3 wound. So there's no reverse staging. And limitations. There are definite limitations when you're staging, especially with non-viable or necrotic tissue, and it's difficult to see on patients with diversity. So people of deeper pigmented skin are higher to assess. So these are pictures that you probably have seen before, and I have little cards that come from Hillrom, and I ordered 100 of these cards so that you can update a little bit. We'll give you some of the words you need to write. Clearly you don't have to take them around with you, but it may help. So a stage 1 injury is really something that looks flat to the skin. It doesn't have an opening in the skin. The skin is not punctured in any way. If you think of it that way, it's reddened skin, can be warm or cool to the touch. Skin remains intact, non-blanchable erythema. So when you put your finger on that skin and you bring it back, the color returns. Any area of persistent color, you want to look at a little bit differently. And redness, particularly in lightly pigmented skin, so my Irish skin will stay red for a little while, whereas somebody who's maybe a little bit darker will not. And anything that persists, the red, the blue, or the purple hues in darker skin, really is probably a stage 1. So stage 2 is a partial thickness. So these are the things that we're really looking for. So you look at that, that's a cute little bump. You can see the biscuits are a little bit, eroded there. It's pink. It involves the upper layer of skin. There's definitely an abrasion. There probably was a blister, but there's a little crater there as well. What I'm going to ask you to do is think about, anytime you look at staging something, if you think it's a stage 2, think of it as that blister you got when you were a kid and the skin came off. That's your stage 2. All right? The blister was there, but it's gone, and you've got open mucosa underneath. So anybody that has a stage 2 that looks like this, guess what? We have to report that. We have to fill out a safety report. And the reason is we're monitoring this stuff to see if it escalates, because if it does...
And this gets reported to the DPH.
The 2s don't.
The 2s don't.
But
3s do.
once the 2 is done, then they'll say, okay, how is that looking this week? How does it look now? Because if it gets worse, if it goes to a 3, it's reportable to DPH. Here's your 3. This is a really clean looking 3. I've never seen anything that looks this clean. But they call it a full thickness wound. So it's involving damage to the subcutaneous tissue. Kind of a deep crater. This is actually a really clean wound. Anything that looks like raw roast beef is a clean wound. Anything that has yellow or slough on it is not what we want it to look like. When I think of wounds around the trach, You don't have clean wounds. You have a lot of sputum. You have suture sites that look like crap. You want to look at that and try to distinguish where is it coming from. Is it pressure from the actual flange or is it from the suture itself? And remember that the depth of the tissue up around the neck and up around the face, head and neck, where you guys are, is not the same. So somebody can go from a stage 1 to a stage 4 like that. Stage 4 is the big thickness loss. So this would be somebody's deep tissue loss, goes down to the bone of the muscle. And when you see a stage 4 in a patient, not a good thing. They always want to look for osteo. If it goes down to the bone and they have osteo, we're talking 6 weeks of antibiotics, someone coming in there and chipping away at that wound before you can even care for it. This is something you do see now and then. So when you look at this, you say, what the heck is that? It's black, it's bleeding. If something's bleeding, that's a good sign. But if it's black, it's covered by eschar. It's covered by something, but it looks really thin. This looks like it's almost like a split thickness skin graft that just got a little dark. We call this an unstageable wound. That black could be hiding a depth of maybe an inch underneath of open wound. And you can tell by pressing on it, you know, whether that's going to break down sometimes. And sometimes it does kind of fix itself. But unstageable wounds are reportable, and the DPH wants to know about it because they want to know, what does it look like 3 weeks from now? Here's another one. Deep tissue injury. So you've probably seen those blistery kind of things. They may be on a heel. They may be on someone's elbows if they're lying on their backs all the time. If you turn someone towards the vent and they go to one side, you may see one of these like bruises on one side. They're called deep tissue injuries. They're purple or maroon. They're usually blood-filled blisters when you see them on the heel, and it's caused by pressure. And when I tell you, you touch that, it hurts, it's mushy, it's boggy. You can see them on arms, anywhere around where the bone is, you'll see this stuff form. It's going to break down. It's not going to break down now, but it's going to break down and it's going to be deep. So if you see a bruise that looks really kind of odd, in an odd place where there has been signs of pressure, it's reportable. You probably see these probably more over in Mass Eye and Ear or in the oncology area of care. This is a patient we have. This is a radiation injury. Most radiation to head and neck, they're going anywhere from 36 to 38 days. They get upwards of 40 to 60 gray. Over the first 20 treatments, they turn a little pink. This happens after 20 treatments. So remember, they've got 16 more treatments after day 20. And this is what they look like. They're burn patients. So this would be something that we have to look at in terms of how we treat a burn. And this is what I just want to show you. In terms of radiation injury, this was a woman that went down, this is laryngeal surgery, came in to try to fix her. And they went to operate on her, and within 12 hours this happened. Look at that. So she opened up, she started draining from here. Her trachea is somewhere in there. That's an NG tube they threw in. And they said, can you pack that? What they wound up doing was taking her back to the OR. She's got her trach. This lady you may remember from a few years back. My point in showing you this is radiation injury to the skin. It wouldn't have happened had she not had that treatment just prior to having the surgery. Things to look for. You're on.
So we'll kind of drill down as to how it mostly applies to us. We'll talk about non-invasive ventilation, different artificial airways, and then oxygen devices and things that you'll see, injuries you'll see with those. So someone who's on non-invasive ventilation, the most common point for skin injury is the bridge of the nose. We've all seen this. We'll talk about in a little bit of ways to deal with this. You can also get an injury in the nair or the septum, depending upon if they're using nasal pillows or infants and neonates. We've seen them a lot with using nasal prongs for non-invasive ventilation. The cheeks and the forehead are usually not the problem places, and it's because most of the pressure is not distributed there. So with non-invasive, some factors that you should watch for is the shear forces, which, you know, you've all seen those patients that you put on non-invasive, they're super agitated, they're thrashing their head around. And as they do that, if you've anchored the tubing, all it does is the mass just kind of shifts back and forth, and that shear movement can cause pressure injury. Obviously, the interface, depending upon where the pressure is distributed, that's where you're going to get your injury, so alternating those can be helpful. And then all these physiologic factors that Marion had mentioned before. So the older you are, poor nutrition, poor perfusion, there's not a lot of fatty tissue to kind of give some protection. just have a greater risk for developing a skin injury. Again, with non-invasive, the duration of pressures is a component. Obviously, if you're on it continuously versus a nocturnal, you're at a higher risk for developing an injury. You guys have all seen those patients where you put on non-invasive for a respiratory failure on these pretty, generous settings, and every time there gives an inhalation, the mask kind of lifts off the face and there's a leak. So then the tendency is to then go just tighten the straps down. But that's probably not the best answer, because all you do is then apply greater pressure when it's not lifted off the face. So you can look at the fit of the interface. If it's not the appropriate fit, you're going to have that leak. Look at adjusting the forehead spacer, which is something I think we kind of downplay a little bit. And then maybe the patient can get away with a centimeter or water to less of IPAP, so you don't have that lifting off the face.
Most of these masks should have some degree of leak around them. The machines are built to tolerate leaks very well. So this concept of tightening the mask down to make leaks should be strongly discouraged.
Yeah,
So
good point.
both the V60 and the 980 will compensate for up to 60 liters per minute leak. So you should be able to tolerate a moderate leak without a lot of pressure on the mask.
Yeah.
It should still cycle, it still should trigger appropriately, even with a significant leak. So the need to get rid of it, as Dan said, is just, just not there.
Yeah.
The ones I think the leaks in the eyes are probably the poorest toleration for those.
Yeah, and that's the problem that patients always complain about it.
Yeah,
a lot of
that's
that's because the mask is too
big.
large.
Yeah.
Right.
Yep.
Yeah.
Yep. So the fit's not right. And then obviously the distribution of pressure, whether it's the fit or the type of interface, and if there's only one pressure, one point of contact, then the degree of skin injury will go up. So the forehead spacer, I meant to grab a BiPAP mask, but I think this is something that we kind of adjust, but then don't take a really close look at every time you interact with a patient. It does two things. So it distributes the pressure both on the bridge of the nose and then the forehead. It also creates kind of a brace. So if you have that forehead spacer kind of away from your forehead, every time the patient moves, the mask rocks on the bridge of your nose. Again, a shear injury can happen. So it kind of just braces the mask from moving so much. So on our BiPAP mask, which you see on the top left, the clips kind of move up and down to get in contact with the forehead. Some of the nasal masks we have, like on the bottom left, they have different kind of foam connections that you can, alter the depth of how far it is away from the forehead. So just take a peek at that and keep that in your assessment when you go around and see people. Obviously, the cushion type, we all know that the gel masks are a lot more gentle, but I don't think that there's an application for gel masks in every single patient. I think for those patients that you've identified that are old, have poor nutrition, have a previous skin injury, that's something that you might consider, or like the neuromuscular patients that we see that use it continuously at home, those are when a gel mask is probably more appropriate. Obviously, various interfaces. I think we've gotten really good at this over the past few years. There's oral nasal mask, regular nasal mask. The top right are nasal pillows. The top left is the hybrid mask, where it has a cover for the mouth and then also nasal pillows integrated with it. The bottom two are just different shaped total face masks. So if you have a patient who has some evidence of skin injury, you can either switch the device and interface completely, or you can alternate, which is something that we do a lot. When those patients who are on it continuously, we kind of alternate interfaces to vary the pressure points. So I don't know if any of you here were for Dean's last in-service, but this was something that he brought up, and I thought it was something good to look at. So this group of researchers looked at treatment-related risk factors for developing skin breakdown. Out of 375 people, there were 54 retrospectively who developed a skin breakdown. They either had a stage 1 or stage 2. Nothing developed further to stage 3 or on. And they found that age, gender, BMI, admitting diagnosis, the average duration the patient was on non-invasive, and the settings really made no difference in whether or not they were more prone to a skin breakdown or not.
So what made the difference?
what they did find was that using using an oronasal mask for greater than 26 hours total duration, you had a real high susceptibility to develop a skin breakdown. The thing I thought was very interesting was with their oronasal mask use compared to a total face mask use, they prophylactically applied a duoderm, and they still have more skin breakdown with it. So something to keep
We've
in
seen
mind.
something like that where patients were using an oronasal mask and they were on it continuously, and the duoderm was there, but
Yep.
on an ongoing, it just kept getting worse, but they couldn't take the mask off and evaluate it.
Right, right.
So is it helpful or not? Is what you're saying? Is kind of
So
a
I think
wash
it's
or what?
helpful, but I thought it was interesting that they took that step to try to prevent it, and they still got worse outcomes with it. Yeah,
Right.
so what they found was that using a total face mask was better than an oronasal mask. I think, you have to take into consideration whether or not the patient will tolerate that. I know there are some patients who absolutely love it and some patients who
We
totally
don't
hate
like
it.
it, right?
So,
But I think the other thing is to make sure you're not tightening the mask too much.
Mhm.
I mean, a lot of these studies, that's a difficult thing to evaluate in the study, how tight, the mask is, and if it doesn't need to be tightened, don't tighten it, let the leak occur, as long as it's, not up above, around the eyes.
And that's including a ventilator leak and an audible leak.
Absolutely.
So this is a different study that I found that they looked at using mouthpiece ventilation with patients with COPD exacerbations. It's a pretty small subject group, but they had kind of applied the fact that people with neuromuscular disease often use mouthpiece ventilation very successfully, and so they said, let's look at it with COPD exacerbations. So as you can see on the graphs on the right, it kind of changed pH, PCO2, and PO2 pretty much equally. So the thing that was different, and that they kind of took it a step further, is they asked the patients, did you like it? They used these Likert scales that, you say always, sometimes, never, maybe. And there was a clinical difference, and most of these COPD patients preferred the mouthpiece. I'm not trying to suggest that this is how we should manage our COPD patients, but I think that I was very surprised when I found this. I would think COPD patients hate this, it would never work, but I was really surprised. And so I think you have to think outside the box. If you have those patients who say, oh, I'm not wearing that thing, then think of something that maybe they will wear, and try different interfaces to use.
So did they switch back and forth
No.
depending upon the patient's awake and sleep status?
Nope.
So how did they do the mouthpiece during sleep?
So if the patient was, if they went to sleep, they, I think they took it out for sleep.
Yeah, I would
So-
have to.
So it wasn't, but for other times, patients who couldn't tolerate just holding it, they used a chin strap, a kind of a securing device. But these weren't the patients who were on it for, like hypercarbonic respiratory failure.
Okay.
You
These
said
are
2
chronic.
hours initially, that.
These are chronic abscesses?
Yeah, with just a COPD exacerbation.
Sounds like IPPV.
Yeah, it does. It does.
Now, Bob.
Old days are back.
So for those of you who work in pediatrics, neonatal non-invasive ventilation is also another issue, another source for potential skin injury. We're using non-invasive more and more frequently with newborns and premature infants, either in lieu of intubation or post-extubation like you would for a COPD patient. And those kids who are very young and have a very low birth weight have a real high risk for developing skin injury. So here you can see it shows a better procedure. You can kind of see how the nares bow out a little bit, so the patient's getting pressure internally from the nares, and then here the mask is strapped on so tight that you see this bulging of skin tissue on the cheek over the mask. So this patient's going to get a skin breakdown underneath the strap as well as at the mask site. These are just some injuries that were reported and published, just so you get a kind of a glimpse at it. And they're all from nasal prong use. So the same thing, I think when we weren't as good with non-invasive ventilation, we wouldn't tolerate a leak, and we would just kind of push the nasal prongs in. And it causes a lot of contact and pressure either on the septum as well as kind of right above the upper lip.
One thing we've tried to remind people, if you look at the opening of the nair, and then look
Sorry.
a little further in, you can see it narrows down considerably. So in the old days, the application was to take the prongs and kind of jam them in to get a tight seal. And what we've asked people to do now is let them sit away from the nair, so that the prong enters the nair, but actually seals a little further in, where that opening is much smaller than the actual opening of the nair itself.
So you tend to use a bigger size.
A longer prong and let it sit down here.
And
Just a
not
longer
cinch it up so tight.
What they have these days is far better.
We've done a lot of work.
Even
We never
the
saw this
nasal
with oxygen.
masks are so pliable. Those masks are beautiful, I
Yeah.
think.
Yeah, so
Yeah.
we've done a lot of work with changing devices and, I don't know, 5 years ago, we only had one type of device in prongs. Now we have several different kinds of masks. We've also made a transition to a ram cannula, which I don't want to say it's a glorified nasal cannula because it has a different application, but it looks the same. And it provides enough CPAP without all of the, the external hardware that creates these injuries.
We don't see a lot of this.
We used to see a lot, and I remember there are kids who needed reconstructive surgery for these
Right.
pressure injuries, and we hardly see it now, because we use different devices, different interfaces.
And people are more vigilant, I think, about it.
Yeah, yeah,
honestly.
yeah. And we cut little duoderms, it looks like a T, so it goes over the septum, so,
Preventatively or
Mhm.
once the ulcer?
no, preventatively, yeah. So to recap, obviously you have to do a skin assessment with every single non-invasive assessment that you do. Try to look for the appropriate device for the patient, whether what meets their, the respiratory needs as well as what they'll be most compliant with, and make sure that the size and the fit is correct. Assess their comfort level, do they have a pre-existing skin injury that they need either a different kind of mask or some kind of skin barrier placed. And make sure the settings are adequate but not excessive, and tolerate a leak. It's okay for a little leak. And then, like Marion said, report and document appropriately.
Should we be using those, like lollipops?
Yeah, we're gonna get to that.
Oh, okay. Sorry.
It's okay. Like she said, artificial airways are kind of a sore subject. So from an endotracheal tube, you can get a stageable pressure injury either on the lip if they're orally intubated in the side of the mouth, or on the tip of the nose and the septum if they're nasally intubated. The mucous membranes have a different makeup of skin, so those aren't stageable, but you can still get a sore and an injury either inside the mouth or the nair, and then we all know very well inside the trachea if the cuff pressure is too high. So here's one that's on the side of the lip. I think we've all seen these kinds of things where you retape the tube in the corner of the mouth and it's kind of pulling a little bit, and so the tissue wants to kind of move in one direction and the ET tube is opposing it. So that's where you get this breakdown. The other thing that I've seen a lot with this is either in emergencies you tape it quick and then tie it because you don't want to lose the tube. The twill ties are, kind of cutting both corners of the mouth, which I think is something we need to pay
They
attention
still
to.
using that tape?
Certain places.
Really?
Yeah, the twill we do, yeah.
Well, this is one thing we may ask for your assistance with. I think we've tried to do this before, and maybe we'll have people more responsive, but there is no standardization, throughout any of the ICUs on how we secure endotracheal tube,
That's
nor
bad.
how frequently we move the position of the endotracheal tube.
Yeah, there's unit
And-
standards, but not across the board
Right, but
standards.
not every unit has a standard, and some units have them, and they are just written on paper. They're not followed.
Yeah,
In the holsters, it's really easy to adjust the tube and move it.
yeah,
It doesn't take a whole lot of effort to do that.
yeah.
But like in neuro, I tried to put a holster on a patient that was intubated and I got noticed for it.
Where are you getting the
Well,
holster?
they
Do
have
they
the
stock
worst
them?
cases over
Yes,
there.
yes, they do, yep.
Yeah.
I got it right out of the supply
Yeah,
closet and I was
different
told to
places
use tape.
use,
Yeah.
it's all over the map. These guys will tell you.
Yeah.
It's a different story every
That'll be
year.
a nice problem.
If you
For
don't
what?
put it on correctly,
I was hoping they're
causes
not
its
still
own
using that tape.
Right.
Of course they are.
Thank you.
Yeah, for sure.
Yeah. So this is what it looks like when it's healed. The thing I think we should keep in mind is, this patient, when he gets discharged from the hospital, he's now gonna have this scar for the rest of his life. The places that we're dealing with are the nose, the mouth, the neck. They're all highly visible areas, and not only does it have an impact on our reimbursement and our costs, but it also is gonna have an impact on our patient when they leave us.
Is that from a tie?
Yep.
Like an evening tie?
It's plastic.
So we're brutal down
It's probably either a tie, or the other thing I've seen is when you put the tape around the tube, if you get a skin fold right at the corner of the mouth, you're gonna get a pressure injury there. And it happens all the time. It's just kind of from the way the tape is placed, and then, the kind of circular motion, it creates this skin fold. So to prevent these, or to try to prevent them, again, frequent assessment, reposition the ET tube, as soon as you see that there's any irritation or reddened area. Again, like you would for a BiPAP device, think about changing the method that you're using to secure the tube. If the patient has an adverse reaction to the tape, look at the Hollister device, and see if that will work better. To prevent the tracheomucosal injury, obviously you maintain your cuff pressures in a safe range. I think we're really good at that. Use skin barrier before you apply the tape, the 3M stuff, and then adhesive remover, which is stocked in all the units except for the NICU, when you're removing the tape to prevent any tears. So obviously with trachs, you can get it at a skin injury at the suture site, under or around the flange, and then also from the ties that we use. So here's a picture of obviously sutures. We've done a really good job. Neil and Marion, kind of before I came here, did a really good job of working with the Churchill surgeons to not suture. Hopefully with the results of that, we'll be able to spread that elsewhere so to get everyone to not suture. But
So who sutures yet?
Surgical.
cardiac
So
surgery,
everybody except the
intervention-
trauma team.
Everybody
interventional
except the trauma
pulmonology and
team.
So
thoracic.
we started June 28th of last year. We monitored the first 50 patients. The outcomes were actually pretty good. They promised they would do a full year study to see how it works, and we'll follow up with them next month.
So how much of a reduction? You said globally 7%. How much
So
ulceration do we have in these?
haven't really worked, we're waiting for the data to finish for the year. I'm just going to ask though, looking at this picture, what do you see? Do you see a pressure injury there at all? I see suture sites to the right.
Well, the stoma.
Right.
Yeah, underneath, where the flange, looks like the flange.
Okay, so if the flange hits it, it is a pressure injury, okay? Good.
So what can be done? It's the physicians who should be held responsible for this, don't
So
you think?
sadly, they don't come
Yes.
back, but they don't
Yeah,
come back.
But the thing is, there are so many times, and especially on your patients on 19, how can we evaluate
Once
that
they're
tube
reimbursed,
that's
they'll
sutured
probably
in, and it's, the whole flange is embedded in the skin.
Right.
You don't want to touch anything, and they won't let you take the sutures out.
So I would have them re-suture. I mean, I know that they don't want the sutures out, but call someone and have them place them so it's.
Will they do that?
Will
You
they
got
do
them?
that? I have never heard of somebody doing that.
So I think
I don't know if anyone's asked them to do that.
so in Churchill, you probably will get that response. In thoracic, I will tell you, I've worked with them for a long time. They probably not. And their philosophy is, if it's a trach R&R, if it's somebody with a really difficult airway, they want to make sure it doesn't move. So they will kill us if we move this stuff ourselves.
Them and Mass Ioneer have some
They're
of the
brutal.
most frightening
So-
scenarios.
And sometimes too, the suture is just in the middle of the flange, which is even worse. If we can get them, like you said, to move the suture to the outer parts of the flange, you have so much room to clean and protect under
And
here.
a lot of times, I'll just go and cut too. And then when
I
they blame
wasn't
somebody, they
gonna-
Right, right, right.
I wasn't going to say that.
I can't say that anybody who's worked with trachs hasn't done
It
that.
just happened.
Yeah.
Right.
The suture
So,
broke.
I mean, you see it, you know what's going to happen, you cut to. I
Well, then
mean,
you also have some pulmonary people who are doing some funny things. So we have a few,
yes.
Well, it'll be good when we get this data. If this data is really
It's gonna help.
different and shows a dramatic reduction, then we have a lot of pressure
Yeah.
that can be exerted
No, when they
from
do-
other sources.
What about
We
those
do
surgical
portraits
trachs?
in neuro.
Massive.
Are we still being, yeah, so we can talk off line
Portraits
after.
in neuro, are they still suturing them?
Yes, I
The
believe they are,
non-Churchill.
but they're not necessarily the trauma team, and it's not one service doing it anymore.
Right.
So we'll change some of the practice there too. So this one here,
Yes.
pressure ulcer.
So you can get this pressure under the flange. Obviously, we've all seen this, a reddened area. And I think a lot of our notes are really good at addressing that there's a reddened area, but then the next step is we have to say what we did to help it. Here's one from a trach tie. I think the patient's neck is kind of to the left-hand side of the picture. And just, the tie being too tight around the neck. And the other thing to watch out for that is if the patient, is perspiring a lot and it gets wet, it just is a great harbor for a potential skin injury.
Or sea collar too.
Yeah, oh, it's awful,
Ooh.
yeah.
Jesus.
So here's another awful one. You guys have all seen these, so I don't think we need to spend time on that.
So you can see, no, the
That's a
incision,
hard trick. That's a hard trick.
the incision is so freaking, it's a
Yeah,
it's a slice and dice.
Mhm.
Yeah, it was
And so
somebody who is
we
not
inherit-
experienced to do
No,
trachs.
experienced
It's just-
people.
Well,
You can see thoracic, cardiac, vascular.
When
Blue rhinos.
No, well, this is it. So this is what we pick up from day one, and then we own it. And we're limited to what we can do.
Actually, we're banking on it. So to get that data from all of the clinicians to
that's
say,
why
you know
we need
what?
these safety reports.
We are looking to say, how do we improve this? And the way we do it is by having licensed clinicians say, look, you can't be doing this. This is really an injury, and we have to report this now. They're getting it. They're slowly getting it. So
So-
prevention is key.
Again, frequent assessment, you have to look at it even every time you go in, look to see if there's any different. Remove the sutures as soon as you can if they're there. Obviously 5 days for a part trach, 10 for a surgical trach. Keep the area clean and dry. Anything that you can do, apply a skin barrier if there's a lot of drainage. And then instead of using the twill tie, like I think Mass Pioneer still uses those sometimes when they come just right back from the OR, try to use the Velcro trach tube that we use standardly.
So dry is best. That's
Yep.
gonna be the best thing to get it to heal.
Correct.
And if something's, we want to keep it exposed, there are still some people putting,
Dressings on. Yeah.
sponges, and you sometimes really almost feel like you want to, the way that it's.
So we're going to kind of go through all of the
Okay,
dressings
all right, good. I'm
so
just
that way we
saying that
kind of have a
You guys,
grasp
we
on
had
that.
a plan.
Yeah. So oxygen devices, although we don't look at these daily, I think with our high flow nasal cannulas, both and masks, all of these areas are potential for skin injury that we have to keep our eyes on. This is a poor patient who has a stage 2 injury kind of all around his face from his nasal cannula. And then this one is someone who secured the nasal cannula behind the patient's head, and then as he laid on the fastener, just kind of made a nice pressure injury in the back of his neck.
You never think just a little kid don't ever do that.
Right.
I don't know.
Yeah. So I don't know if you were here for it, Christina, but we used to have these off-flow nasal cannulas that cause a lot of pressure on the ear, and then we changed the whole device that they're much more pliable for this reason. So the
Yeah, do we
difference.
see any like this anymore?
Yes, we
We
still
still
do
get
sometimes.
nasal cannula?
We have those little cozy
Because
things
that
that
new
go around
one-
the mask.
The one we have, I would think we should.
The one you have is terrific. Sometimes those other ones show up now and then.
Well, the patients come in with them and nobody takes it, changes it, right? Okay.
So the different skin barriers that we cannot use, the first one is the 3M no sting barrier film. So it's just the lollipop. It just really provides an extra layer of skin, and Marion, I'll steal what you said to me. It acts like Teflon. So Marion had me put it on, and it gives
Put it on
you,
your hand.
it gives you like a shine on your skin. And then when you wash your hand for the rest of the day, you'll see the water droplets just run right off that area.
At what stage would you choose to put a duoderm instead of a Teflon over the wound?
Once there's a broken
You don't want
area
to-
of milk,
Yeah.
So if it's reddened, you can do
Still
this.
do that.
cover
Yeah.
everything that drains with this. If it's around a trach, if it's around a potential area of breakdown, it's an extra layer of skin, and it's Teflon. Anything that drains rolls off.
Shouldn't we be doing this preventatively almost?
Yes.
You ought to just have these in our pockets.
Yes.
Yeah, so I think every time you do trach care, whether, even if the skin looks intact, you should put this around it.
So-
Before you put a BiPAP mask on, put it on the
So this
nose.
is a good preventative.
So
Exactly.
where do we
Very-
find these?
They're in
They're on
every
every
utility
floor.
floor.
Are they on every floor now?
Every floor.
And this should be in the rooms
Right.
as
So
well.
it's in the-
And then
It's
there
really
was a
hard.
small
I've never seen a
little-
Made that
patient
happen.
have
They're
them.
there.
Yeah.
Okay,
Yeah, they're in most
So
of the
before you
carts.
put the tape
Yeah.
on for ET tubes, put this on the skin. It will just help
It's
everything
better
come
than
right
tincture
off.
benzoin.
Yes.
Very much better. The Duoderm, I think, is something that we use a lot of. I'm sure you guys have all seen these. It's a hydrocolloid dressing. And I think you trim it to the right size. I think anytime you see that the flange could have the potential of digging into the skin, you should put it on for that. And then this, correct me for the number of days, Marion, but you can leave this on. You don't have to change this every time you do trachea, even if it's starting to pull off. As long as it's covering the affected area, you can leave it on.
So if you saw somebody that has, remember that blister, and then the skin kind of sloughs off and you see an opening, and you think, on anybody else should throw a Band-Aid on that. You could put this on it. Even though it's an open area, you put that on it, and it's treating it.
It breathes?
It actually treats it.
But
So-
does it breathe? I mean, is it able to get air to that? That's the whole thing that I'm hesitant about
Yeah.
slapping anything extra on.
Yeah, and so this works miracles, I will tell you. We put them on stage 2 injuries as treatment of choice.
Waters through. Doesn't
Here,
this let
I got
fluid
it.
through?
It sucks in the fluid.
Right, I mean, it lets fluid through, so if it lets fluid
Vapor
through, it'll let air
permeable.
through.
Right.
Okay. So you will see if there's an opening where there is an injury, it'll start turning white, and you'll say, oh, this looks dirty, I'm gonna take it off. Like any nurse will just rip it off. Don't rip it off, leave it there. Because when you do eventually take it off, it'll lift, the skin will be healed. It's really cool.
Really?
This stuff is awesome.
How about with the teeth?
Pardon me?
Like sometimes in the isolata, like you melt into the.
Yeah, it's okay, let it melt. You can pull it up.
So Mepilex is another dressing. It's a kind of spongy, foamy dressing. It's good for those that are low to medium draining wounds. It can be trimmed to any kind of size that you want. And sorry, I seen this one time that someone put it on the nose for a BiPAP, and it seemed to almost work. It was counterproductive because it kind of raised the nose and then created more leaks. So then the tendency again was to strap the mask a little bit tighter. So, but it is. I mean, you can cut it for anything, any size that you.
Our population of patients, we use it immensely for commissures as well. We cut it straight in half and put it in between the 2 ties we use for our burns, and we protect the commissures that way. They used to make like clay, but they don't make it.
So, I mean, these for under a trach, I mean, this is pretty thick and it's gonna cause a
So
trach
these are
to
new
tip.
coming in.
Those.
We're gonna trial those.
Okay, so, yeah, I mean, that would be my only concern about these things being put on a trach. It's just like putting the gauze you used to put, then
Underneath,
pushes. Okay,
For a while, they were throwing them on top of the tree.
That's
and
what-
they wouldn't even say
Yeah, but
it.
we were doing that because of the yeah.
It's like,
So the Mepilex border is this one that looks like a fancy Band-Aid. Again, it's good for draining wounds. It's difficult to cut though for something that that we would apply it for. Obviously, a big square doesn't really fit over any kind of respiratory area. So when you cut it, you kind of lose the ability to seal all the way around. And then the live foam tees, there's 2 different kinds. You'll see that one's coming and one's the one that we have. It comes pre-cut to go underneath the flange, and then it's good to absorb highly draining wounds. So it wicks the secretions away from the skin to try to keep the skin dry, and you just change these as soon as they get soiled.
Those are nice.
Yeah. So this is the issue that Bob was just talking about. The liafoam that's on the left is the one that we used to have, and you can see the difference in thickness of the 2. So that one we were hesitant to put underneath the flange for fear of displacing the trach, so we were putting them on top. And then there was a huge concern that if the patient moves and it occludes the trach, then the patient can't breathe. So we made a transition a couple of years ago, I think, to these ones on the left, which work still the same, but they're much thinner.
And they're coming in even thinner still. Another company is going
great.
to.
They seem
We're
to
working-
even thin when they absorb this liquid as
Yes,
well.
yes.
So prevention is key, and frequent assessment is key. So you have to look at it, you have to, put the 3M barrier on, put a Duoderm on. If your patient, has a neuromuscular disease and they came in for acute respiratory failure, put a Duoderm on their nose before you put their BiPAP mask on. It won't necessarily prevent anything, but, it will definitely help. Talk to the nurse and then the physician care team about either changing the tray to a different style flange if you notice that there's some kind of injury starting. Vary the interface for non-invasive ventilation to vary the pressure points. And then obviously all these skin barriers are great. So you have to document, like I said before, document what you see. You don't have to stage it. We're not trained to stage these things. But if you see a reddened area, write that it's reddened. If you see an ulcer, right, there's an ulcer. And then what you did to treat it. I'm not an expert on what dressing to put on what, but that's why we have the CNS consult. So they know what to do, and you can say that I saw a reddened area and I spoke with the nurse, or I put a Duoderm on it. Just make sure.
In your note.
Yeah, in your note, that there's that follow-up piece of what you did, even if it was just communicate with someone else. So we want to make sure that documentation's in the eBridge note, and then, again, we should be filing safety reports for anything that's what looks like a stage 2 or worse. Don't fear that you're going to over safety report, even if, the CNS looks at it and says, oh, that's only a stage 1, we didn't need a safety report, it doesn't really matter. At least it's, documented and someone's following it.
So stage 2 is a blister. That's the thing.
The broken blister.
The broken
Broken
blister.
skin.
So distinguish between the broken blister
And
and
red.
that macerated area of so many secretions, it just looks like the worst diaper rash ever.
Right, a red rash that's not broken down.
Right, that's just
Do you
painful.
think it helps with that or makes it worse?
So it depends. I think if you can dry up the area enough and protect it with, and this hurts going on an area that's already broken, but if you can dry it up a little bit, then that will absorb, and the key is just replacing them. It's really care.
Yeah, so if you have like an open wound underneath, do really good care, get it all dry, put a Duoderm under it. And then if you're still having drainage, like around the stoma site, put that on it. So you have it at least protected, you don't have to keep drying it, but then you're dealing with the secretions and the drainage with the liofilm.
Not the wet drain pants, that doesn't help. The moisture from that. It's almost like we should develop some
So
kind
that's
of a
why we started
T-tube
doing
type-
this.
T-tube type of thing, like the old days, which is scary.
Then you're gonna have
Yeah,
that
I
What's a
know.
T-tube?
potential for shearing.
Like a braid,
Injury.
they call them
bridge?
braids.
Oh,
No,
yeah,
what
I remember the
T-tube?
bricks, yeah.
Yeah, we
And
would do
also-
with that, but they need something more flexible. So these are the patients who are constantly, I know it's coming from around the trach,
Yeah.
but they cough it up and it sits there. Nobody's there 24/7, nobody catches.
And
But
I think that might be a good solution, again, think outside the box. If you have a
Yeah,
patient that
yeah.
has a significant injury that the heat and moisture's not good for, maybe that is the answer.
But then that
but
puts
it's-
tension on.
Yeah, I
food
mean,
when
we
they
have
move.
to, kind of weigh the pros and cons of each.
And
And I think,
yeah.
I think it's not the way to go standardly, throughout the hospital, because, not everyone
You get a lot
has
of
an open skin.
cannulations,
and-
too.
Yeah. So-
Sometimes they can choose the T-tube, T-piece. Are you talking about a T-piece right now?
Like we sometimes will put an inline on.
Yeah, yeah.
Oh, yeah,
I think we're talking about the same.
yeah. And then that CNS consult, there'll be further education for our group when it's actually live, but just know that that's someone that you can reach out to. And even this consult, if it's not tomorrow, if you see one and you're in Elsa 19, knock on Marion's door. Well, maybe not tomorrow, because she'll be there, but so knock on the door
I'm
and
not
say,
coming into markets.
hey, I need you to come and look at this, or talk to the nurse and say, can you involve your CNS in this, because this is something that we need somebody to look at.
But more importantly, if we can get you to actually file that consult, then it's listed. And we look at that every day, and there's an actual way you can go back and check, has it been done?
Are we live on this, and is there
No.
any way to
Not yet, we're working
know?
on it.
Is there any way to know that
That
it's
it was done
already been
before?
done?
No.
That's what's
So that's-
messed
But so
up,
hopefully that will be put in a report.
right?
You won't get direct feedback when you put in a consult. Like, Mary's not going to email you directly.
Right.
But they write a note in CAS, so, or an eBridge that then goes to CAS. So if you notice that there's already a CNS note, you know,
While they're working
You
on
could get
this.
feedback in a safe room, though.
Right,
Yep.
safety.
Epic.
Yep.
so we
All
should
of
do
this
both.
stuff,
It's
the
not
new
either,
program,
okay.
because I think that our
Epic will be
e-bridge
able to
notes are
run-
not really good for this
Right.
right now. You have that one-liner, and that thing that's on our, when we validate, well, that's good to look at that, but nobody looks at that.
That's
So,
why
I
we were
mean, to
trying
do
to
something
get
like
these
that
for
in the
people.
e-bridge,
Yeah, needle and
in
nerves and
the
things.
Epic, to have it,
So you'll be getting some of these that will help you get an idea. It also gives you the verbiage, like what to say. Girls say icons. Honestly, too, you guys are gonna be the experts at this more than many of the CNSs are. Not everybody's at the same level of assessment, but it focuses them to, when they go see what this is. So we have an accountability, that there's actually closing the loop on a lot of these injuries, which makes everybody happy, which makes the DPH happy, which gives us reimbursement, and the patient ultimately benefits.
when a patient
The other
comes
thing-
in, comes down
Well, I was just gonna
something
say
too.
that we
That's
need to
huge.
document
That's the one you
directly
want to
right
document.
away, whatever you see, you know, when a patient comes in with an ET tube, you know, it looks secure, you should untape it and see what's underneath. Because you never know when it occurred, and for reimbursement purposes, we want to make sure, like she said, that they know this was there before their admission here.
And we have them come in, and they get worse. I mean, I had somebody with a stage 4 that actually came in as Lamy. You guys took care of her, right? Her son was an ENT guy. He basically put her to sleep for a 12-hour plane ride. When she got there, she had a big bruise on her butt. Turned into a hole, turned into a stage 2, 3, 4 osteo.
COPD exacerbation, and half of them you put on BiPAP and half of them you put on high flow nasal cannula. And then you see what the intubation rate is in both groups. And even if you did that study and the intubation rates would be exactly the same in both groups, might make a case for high flow nasal cannula. I think it would be easier to go out and put somebody on high flow nasal cannula than to, fit the mask and titrate the settings.
I have a question.
Food for thought, though. So you did not hear it from me that we're going to start using high flow nasal cannula for acute COPD.
This is something different. I only used it. I used a cannula maybe 4 years ago, 3 years ago, just once. I do not quite picture this. As the bore goes down, it becomes a nasal cannula. Those 40 liters, the gas itself needs to acquire an incredible increase in velocity in order to maintain 40 liters.
Right, it really jets
So
into
yeah,
the nose.
almost like daggers,
Right.
a package of daggers going.
Particularly if it's not warmed and humidified.
That is the question, yeah. So people that occasionally we put on the nasal cannula, we kind of look at the liter